This is BMS 205, Module 2, Part 1, and this is Professor Stileski. I am reminding you that you are encouraged to take notes as you view these lessons. Learning objectives for this module include defining or describing diagnostic signs, symptoms, reference ranges, which we sometimes call normal values, screening tests, pathogenesis, acute disease, chronic disease, positive and negative predictive values, pathology, in vivo, in vitro, morbidity, mortality, sensitivity, and specificity. You'll explain how a pathologic condition impacts the homeostasis of the body, identify and explain the essential steps in the diagnostic process, describe potential predisposing factors for disease, and explain conclusions regarding responsibility for safety in medical diagnosis. Let's begin with the diagnostic process. Accurate diagnosis of disease is one of the most important aspects of medical care. Diagnostic testing may date back to 1612, the year that the physician Sanctorius developed a thermometer to measure body temperature. Today, temperature taking remains one of the most basic and routine diagnostic tests. It is safe to say that diagnostic medicine has witnessed more revolutionary changes in the last 50 years than in the previous 2,000. Before the advent of modern diagnostic tools and techniques, diagnosis of medical conditions was often a best guess. From the time of Hippocrates, 400 BC, until the 1800s, physicians had little in the way of diagnostic aids. The first stethoscope was invented in 1819 almost by accident and was little more than a rolled up sheet of paper. It would be several decades before physicians universally accepted that listening to a patient's chest was a good diagnostic tool. In the late 50s, physicians began performing complete physicals, which included examination of the eyes, ears, listening to the heart and lungs, and a history of the patient's symptoms and family medical history. New technologies foster new scientific modalities for patient assessment and clinical intervention. New technologies have greatly improved developments in total body and brain X-ray scanning, digital and enhanced imaging, magnetic resonance, positron emission tomography, genetic studies, markers for cancer diagnosis and prognosis, sleep disorder testing, technology for fetal testing before birth, and postmortem testing after death. New technologies are faster, more patient-friendly, more comfortable, and provide a higher degree of accuracy. Non-invasive and minimally invasive, terms that you should know, testing in non-traditional settings continues to change the field of diagnostic medicine. Where diagnostic testing was almost always performed in the acute care hospital, we now find testing available in outpatient departments, physician offices, clinics, community-based centers, churches, stores, and pharmacies. This challenges medical professionals to provide safe, effective, and informed care. We tend to say that 70 to 80% of objective medical decisions are based on testing from diagnostic tests. And objective medical decisions are those that are made based on data versus subjective things such as a physical exam or symptoms. In the 70s, the physical exam began to be replaced by chemical and laboratory studies. Advances in biomedical testing allowed physicians to obtain large amounts of information from a few tubes of blood. Some do call the 70s the age of the chemical exam. Today, the ability to provide large amounts of information about the patient from just a small amount of blood continues to expand. Molecular diagnostics, the ability to detect infectious organisms from their RNA or genetically inherited disease, is at the cutting edge of diagnostic medicine. You can see in these images some views of instruments and information provided by modern diagnostic tools. Medical imaging techniques are leading the way into the age of imaging. Just 100 years after the discovery of the X-ray, computers can combine hundreds of images to provide 2, 3, and even 4-dimensional views of internal organs. The incredible advances of the last 50 years are reflected in an ever-growing number of tests and procedures. Diagnostic testing is the fastest growing and one of the most costly areas of medicine. There is much more pressure from the government and insurance industry to keep costs down. The pressure to control costs could result in inadequate diagnostic testing. It is important to be informed and to know where to go for information to ensure that you seek proper medical testing when you need it, and that as medical professionals, we know when to advocate for our professions and for the good and safety of patients. These images show some additional advanced types of diagnostic imaging equipment, as well as a couple of other diagnostic procedures, including EKG and point-of-care testing. Diagnostic tests are used for many different reasons. The most common and one that we're most familiar with is establishing a diagnosis. Of course, using tests to establish the diagnosis is a significant component of medical diagnostics. Other uses for diagnostic tests include screening, such as tests that are used in health screens, and we will discuss many of those this semester. A good example of diagnostic testing used in public health is lead screening. We will examine the use of lead screening as a public health measure in the next module. Differential diagnosis involves deciding between two or more diseases that present with similar symptoms. Diagnostic tests are essential in making a differential diagnosis. HouseMD, if you watch that show, is a great example of the use of diagnostic testing to rule in or rule out disease. Diagnostic tests are also essential to monitor treatment and medications. This type of testing is known as therapeutic drug monitoring. Other diagnostic procedures are actually used to treat a patient, such as in radiation therapy. A significant use of diagnostic tests is to monitor the progression of disease or treatment. Examples of these include blood glucose monitoring, cholesterol screening, CT exams to evaluate the effectiveness of cancer treatment. We also use diagnostic tests as predictors of disease and for forensic or crime-related purposes. Although this image is from a crime investigation show, all medical diagnosis involves detective work. Stop the playback and click on the picture for a short video about diagnostic detective work in the clinical environment. How is diagnosis made? All diagnoses begin with a similar decision-making progress in which data is collected, analyzed, integrated, and interpreted, beginning with the collection of symptoms, history, physical exam, considering the individual risk factors. This is the patient factor. We evaluate signs, including blood pressure, temperature, respirations, request and interpret diagnostic tests such as laboratory imaging, and then correlate the information or interpret. The interpretation and correlation is by far the most important part of formulating a diagnosis. Risk factors are important in formulating a diagnosis. Risk factors are always patient-related. They can include things that can't be changed, such as age and gender, history of chronic illness, family history of illness, or things that can be changed, such as lifestyle or occupational exposures. The first piece of the diagnostic puzzle includes evaluation of symptoms. A symptom is a departure from normal and is subjectively described by the patient. A sign is an abnormal objective finding, something that can be measured, and we might consider it evidence that is found on a physical exam or by diagnostic testing. These are terms that you should know and be able to define. Terms related to symptoms include chronic, which implies long-lasting, relapsing, symptoms that come and go, and remitting, which improve and go away. Consider types of symptoms that might be chronic, relapsing, or remitting. Pain is a symptom that could fit all three definitions. We also have to consider the term asymptomatic, which means that no symptoms are present, even though there is disease. There are examples of perhaps certain cancers, actually many diseases, where the patient may actually have a disease but does not currently demonstrate symptoms. We use the term subclinical when we are talking about infections. Subclinical meaning that person has an infection but is not demonstrating any symptoms. The absence of symptoms is problematic, of course, because symptoms are very useful in helping the clinician go down the correct diagnostic path. We should also know the term presenting symptom, what brings the patient in for care, and the cardinal symptom, which is the symptom that is often the key to diagnosis, helping the clinician choose the right follow-up and diagnostic testing. These terms apply to signs. So a prognostic sign is a prediction. Remember, signs are the measurable or objective types of information used in diagnosis. An anamnestic sign means it's something measurable from a past occurrence. A diagnostic sign, so these are tests, helps identify disease, and pathognomic sign, again, measurable information, is definitive of disease. So we'll go through a number of different examples of these as we consider different types of diagnoses and diagnostic tests. These are some additional terms that you are responsible for. And pathology is the scientific study of the essential nature of disease. It's a description of the traits, causes, and effects of abnormal conditions. And abnormal conditions are called pathological. Homeostasis is the normal steady state of the organism, so it's the system of checks and balances that keep a person healthy, the condition that we hope to maintain. Pathogenesis is the course of disease. So some diseases start slowly and continue for a long time, and we call them chronic. Some present quickly with symptoms and may run a brief course. That doesn't mean the patient always recovers, but we call these acute diseases. So the pathogenesis or course of disease depends on the patient, the cause of the disease, and of course the medical treatment that the patient receives. When we are properly conducting diagnosis and diagnostic tests and use screening tests properly, we hope to reduce the morbidity, which is the incidence of disease, the ratio of sick to well in a community, or the mortality, the fatal outcome or death rate. Of course, we hope to reduce both of these, and you should recognize the terms morbidity and mortality. We should also talk about the phases of diagnostic testing. So in the diagnostic testing protocol or lifespan, we have the pre-analytic phase. These are things that affect the patient, such as the collection of information, informed consent, proper test selection, getting the specimen and getting it to the testing site. The analytic phase, which is what happens in the imaging suite or the clinical laboratory or any other diagnostic area. Post-analytic involves generating results, reporting follow-up, result interpretation, follow-up of tests, patient counseling, and record keeping. So quality management is essential in each step to ensure good patient outcome. Errors can happen in any part of the system and will likely have downstream effect on patient outcomes. We'll spend some time talking about quality assurance in the different phases of diagnostic testing as well. We previously considered that the interpretation of diagnostic tests is one of the most important features of the diagnostic process. So how do we interpret the results of diagnostic tests? One way is with reference ranges. So a reference range is the usual range of a test for a healthy population. We also call these normal ranges. Important to know that reference ranges are determined by each laboratory for the patient population being tested and the test method. Some methods are standardized to national norms, such as blood glucose or cholesterol. However, there can be some variation between reference ranges at one institution versus another. Factors that affect test results include age, sex, pregnancy, diet, diurnal variation, even geography, and ethnic background. All of these factors need to be considered when establishing reference ranges. So here's a word to the wise. The comparison of normal values or reference ranges requires careful evaluation. Some tests are standard. Many tests vary between facilities. So the take-home message here is that a person who has a result outside of the normal range is not necessarily carrying disease or ill. We do need to consider that there is normal statistical variation when we determine reference ranges. So most reference or normal ranges are set to a particular confidence level, usually 95%. At 95% confidence, 1 in 20 results will be outside of the defined range, even though there is no abnormality in the person. So this histogram demonstrates the three typical confidence intervals of 1 standard deviation, 2, which is 95%, and 3, which is close to 100%. So when we apply statistics, we know that 1 in 20 or 5 in 100 people can be outside of the normal range without actually being abnormal. That's a statistic you should keep in mind. This is the end of Module 2, Part 1. So you should continue to assessment for Module 2, Part 1, and then go on to Module 2, Part 2.